This is Let's Talk About Health in Africa on Utano Podcast with me, Lenias Hwenda. Today on Utano Podcast, we are talking about the current state of medicine's quality and safety in African countries. My guest today is Colin Shamhuyarira, who is the Chief of Party for the United States Pharmacopeia, which is also known as USP in Rwanda. Colin, welcome to Let's Talk About Health in Africa on Utano Podcast.
Good morning, Lenias. Thank you for having me. I'm happy to be here.
Wonderful. Colin, many parents, myself included, who have seen the headlines of children dying after taking poisoned medicines in the Gambia and in other countries around the world are very worried about the quality and safety of the medicines that we are taking in Africa, the medicines we're giving to our children. Those children who died could have belonged to any one of us. How would you describe the state of medicine's quality on the African continent today?
Okay, thank you. Thank you very much for raising that important and very pertinent issue that is involving in our African continent. So my take, basically, based on the experiences and also from the interaction that I've had within the African continent, our quality systems or our systems to manage medicine's quality in Africa are not yet at the expected levels we want them to be. But however, there's sort of a lot of things that are happening in the background, so many activities being done to actually improve and make sure that we have expected quality of medical products being given, being used, or being found in all the African continent, even though we still have scattered places or countries where quality is not yet a defined parameter to an extent that is expected. But however, efforts and a lot of activities are being done to make sure that we can bring the issue of medicine's quality to the required expectations, both internationally and also in our own background in Africa. Coming to particularly the incident with the Gambia situation where we lost a number of children because of poor quality medicine that was consumed. My take basically is mostly because of the pressures we have in trying to ensure that medicine is available. The first case is availability of medicines, and then its access. So normally, because of that kind of pressure, we then put the role of quality, at a later stage than making the medicines available in the first place. We have got challenges in having these medicines because they are not manufactured locally in most African states. I think you understand that we have got less than 10% of medicines that are manufactured within the African continent. So the idea of quality becomes more secondary in most cases because of the issue to do with access. We have to make medicines available in the first place. So it is in that circumstances that those who are bringing in medicine to Africa, sometimes they take advantage of that system where they know that we don't have much in terms of quality system put in place, because we are much worried. We are more worried on the issue of access. We have the medicine in the first place. So they play that role to try to push the medicines they know they cannot be sold anywhere, where quality checks are strictly a priority before a medicine is accepted into any country for any consumption by any nation. So that's where my take is. Since we are now focusing not only on the issue of access now, because of that incident, we now need to reinforce our quality assurance in the quality control systems to ensure that only good quality, safe, and effective medicines are in our shelves.
It's true that, in that case in the Gambia, the manufacturer actually knew that the medicines that they were selling were problematic. Apparently, they had already been given warning by the Indian Medicines Regulatory Authority, and yet they still shipped those medicines. So clearly a case of a company that is taking advantage of the weak regulatory environment where those medicines are destined to go. Now, Colin, you've spent your career of almost 20 years or so as a regulatory professional, both in industry and in government. Talk to me about how you have seen the medicines regulatory environment, the medicines regulatory industry evolve on the African continent in the last 10 to 20 years.
Oh, thank you very much. I will be very, very happy to talk about that. Because basically, when this idea of regulation came to Africa, we were not very much, as I said, we didn't too much, resources. We didn't put too much, ideas or any, policies and so on. It was something like an afterthought. After all, we believe that medicine that is coming maybe from the developed countries are already good quality. But however, because of awakening now systems due to WHO, which has been working more in Africa, trying to make Africa understand that there is a need for Africa to regulate medicines. So there are a lot of steps that have seen development, reinforcement and involvement of even new countries that didn't have regulatory frameworks or regulatory systems. So we have seen a lot of countries getting involved, starting to regulate medicines in their own countries, even though we have got our regional economic groups like the SADC, the EAC, ECOWAS, and so on, also harmonizing, harnessing all those things to push forward for a better regulatory systems. So there's been a lot of happening. We see a lot of countries developing, and we can actually see what happened to countries like Tanzania, countries like Zimbabwe, Namibia, South Africa, or Nigeria, all over. In most African states, Ghana, they have built very strong regulatory systems, which are a good testament in the current environment, where they've done very well, exceptionally very well, considering the constraints that Africa has, considering the issues to do with expertise, infrastructure issues, and also even financing. And that has seen almost every country in Africa now trying to develop their own regulatory systems. So I have seen, when I joined pharmaceutical industry early 2000, you could hear one or two regulatory bodies in Africa. There was Uganda, India, you could hear of Ghana, you could hear of TMD, Tanzania, you could hear of NAFTAC. But now we talk of almost every country now has or is in the process of developing a national medicines regulatory agents or systems within their Ministry of Health to make sure that the medicines are being regulated properly. So there have been tremendous, growth, tremendous development, and I am happy because Africa is starting to realize the importance of the regulatory aspect, which was not their priority in the first place. But because of the need, to have your own systems, the need to own your own space, the need to determine things that come into your country, the need, to develop your own way of accepting things, even though the international standards that are in place. But Africa has seen it as a very good and a great opportunity for them also to develop and strengthen their own systems. So a lot has happened. We now have got SADC with a very good framework, for example, Zazibona, where there's now a lot of working together within the region. to assist each other, because we understand not all countries have the same level of capacity in terms of regulatory systems. So the idea to come together, the idea to work together is trying to balance where the some are lacking, and then we take advantage of those that have already developed, and so that we can work together and try and regulate medical products in the proper, effective, and also accepted way. So yes, the industry is on, and the industry is still growing, and it's going to be great as we welcome the African medicine agency, which will then be able to support and oversee and then provide a regional perspective to the continent. So this is a growing industry. We expect more to be done. We expect all other areas to be covered, like vaccines, regulations, medical devices. We are adding a lot of devices that were not initially thought to be regulated, but now they are coming into play. So many, even blood and blood products, radiopharmaceuticals, and so on. So all these things, it's because Africa is learning and Africa is developing.
So a lot of push, big push to improve the regulatory environment, with countries aspiring to do better and doing a lot more to improve their regulatory space. Now, where have you seen, amongst all of the different areas, you mentioned medical devices, and there are, of course, medicines, their diagnostics and laboratory capacity. Where have you seen the biggest improvements in regulatory capacity, and where are there still big gaps that needs to be filled?
So, as I said from the start, that the major option or the major issue was to do with access and availability of medicine. So the first port of call, which became a priority for all of the regulators and for all international organizations like WHO, was issue to do with market authorization, registration of products themselves to be accepted in different countries. So a lot has been done. There's been a lot of regulatory strengthening systems specifically for market authorization, so that a lot of products can be evaluated, can be registered, can be accepted in different countries. So that, to me, was the biggest side, which had received so much support from technical partners, funding partners, and even national governments themselves. They have put so much in that space so that we can increase, the level of medicines coming into country, which are coming the right way. So that was the best, or the first area that had so much improvement. And even, we talk about all these regional bodies like the SADC, the EAC, ECOWAS, they all started with market authorization, registration of products. So that was the first, which was most supported a lot, in my view. And however, the other area that was supported a lot, which is developed from market authorization, was the regulatory inspection side, where regulators need to inspect factories, manufacturers, for good manufacturing practices, so that they know that where the medicine are coming from are being manufactured properly. And that is also followed suit. However, we have got the other arm of registration of product, registration, the quality control aspect, which has lagged behind to these two. Because these two, market authorization, regulatory inspection, and the quality control. So quality control is not yet at the level of market authorization. It's also not yet at the level of regulatory inspections. Why? I think basically because quality control requires a lot of investment. Infrastructure, number one. Number two, governance systems, how to govern those labs. Number three, capacity in terms of the actual quality control activities, competence, resources like equipment that are needed to do quality control, testing and so on. So it lagged behind because of investment required. However, a lot has been happening, and they are still happening to ensure that quality control is also uplifted to same levels with market authorization and regulatory inspection. So there's a lot that needs to be done on the quality control side. And I'm happy that a lot is also being done to ensure that quality control does not lack, does not become the burden in trying to defend whatever is being done along the whole cycle.
Yes, so if quality control is lagging behind market authorization, inspections, and all these other areas, what do you think needs to be done to bring it up quickly? Because if we have situations where children are dying from taking poisoned medicines, obviously we need to do more to really bring the quality control aspect of the supply chain management to the right level, to make sure that things like that do not penetrate borders and get into the hands of patients. So what needs to be done in your view to improve this?
So according to the WHO GBT2, the global benchmarking tool, which has defined how regulators should be governed, should be operational, should be institutionalized. The first thing that has been giving the quality control side a challenge basically is the issue to do with the legislative framework, to actually identify the need for the labs, because this is the legal side of the story. You can't just start, providing regulatory oversight without a proper legal framework. So the first part of for me is to ensure that all African states develop proper legislation that covers all activities for the national regulatory authorities or agencies in their countries, such that quality control becomes also a pillar of that. Because there are three key pillars to regulation of medicine: the market authorization, inspections, and quality control. And because of the issue to do with investment, to do with capital required for laboratories, governments, I have seen it myself, they've done a lot. They have now realized the importance of these labs, and they've started now to develop these quality control laboratories as part of their national regulatory agencies, so that they can be strengthened in the same manner market control, market authorization has been strengthened, regulatory inspection has been strengthened, even market control surveillance has been strengthened. So priorities have to change. They have to be balanced. Governments, institutional partners, development partners, international, communities who are supporting these electoral, they now need to also put more effort and also much funding to the quality control side. Governments through their Ministry of Health or whatever, the ministry lines, they now have to have a proper definition of what they need to do, how they need to do, and then be able to look for funding specifically to institutionalize quality control facilities. And then the second option is we also need to develop, the quality and the level of expertise that is expected to work in those labs, which also became one of those key issues that has delayed a number of institutions to have them, because it's not easy to have the level of quality expected to provide the proper oversight to quality control activities. Remember, we're talking about a lot of things here. We're talking of medical devices, we're talking of medicines, we're talking of vaccines and biologics, we are talking of other areas like cannabis, cosmetics, which comes in the same bracket. And we need to have all the expertise that can critically support this. So it is very important that we be very intentional. Academic learning of higher institutions should be able to provide much needed capacity in terms of training and providing adequate, quality and qualified graduates who can be easily trained and become competent to carry out these quality control activities. And then once we are done that, obviously, we need now to equip the systems, we create proper working systems, and then we constantly be able to, to move up, continuously improve, see what's happening in the industry, and be able to equip continuously and do continuous improvement, so that we can be also be at the same level with all other regulatory bodies in the world. And I'm happy that WHO through the GBT2 is trying to level that field, where they also look at the laboratory systems to check how they are institutionalized, how they are operationalized, and how they are competent as they fit into this war framework. So yes, what needs to be done is very clear. Be intentional, create a proper program, and then develop infrastructure how you want. And then if there is need to seek for funding, partners to help them, then we go that route. But if the other part that is critical, as I said, will be to have, training critical skills that will be able to support that quality control activities.
Are we testing enough with all of those limitations in quality control so far? Obviously, if it hasn't been a priority on the same level as registrations and inspections, how much do we test compared to what the threshold we should be achieving to make sure that the medicines that people are taking are of assured quality?
So let me draw you to very critical issues about testing, which we also need to understand very well. So testing is not just testing as people always talk about it. There is a lot that comes into it. So the first protocol is we need to understand what we need to test. Remember, we are talking about medicines, talking about vaccines, medical devices, biologics, and so forth. They come in various forms, types. And the key bottleneck in all these testing issues is Africa is not manufacturing the quality control analytical equipment or instrumentation that is required to test all this wide range of these medicinal, of these medical products. Let's take, for example, just our normal medicines. The level of investment that is needed for you to test the whole range of medicines that come into your country is quite enormous. You need equipment that costs millions of dollars. You need to have systems like, uninterrupted power systems 24/7, so that we don't disturb the systems we put in place. So yes, to answer your question, we are not testing enough. And if things remain the same, we will never test enough because of the issues to do with capacity challenges. That's why I have said we also need now to adopt with these systems that WHO is encouraging continents to do, the reliance aspect, to rely on one another, regulatory reliance, create these regional hubs. For example, I can only relate more to the SADC, which I was involved. This bonus system. We can then put the quality control arm of this bonus system and identify labs that have got competence in certain areas in the whole continent, in the whole region. Say, for example, one might be competent in testing certain type of medicines, and the other one is competent in another area. We then pull our resources together. There is no need for all of us to test at the same level, because capacity is not the same, and competence is not also the same. So if we then do the same strategy, like what disaster bonus do for registration of medicine, they come together, they do inspections, and then decisions becomes later, but the actual work is done collaboratively. So we can also do the same approach, create networks that are viable, networks that work, networks that produce results. We give one country, capacity. We help it capacitate to the level expected for a particular section we want. Say, for example, a certain critical, for example, for the Gambia, medicines. Those chemicals are not easy to test. You need a high-tech equipment, very expensive, more than 200,000 for equipment, and to fully test everything for 5, and you need $1 million to invest. It's not every country can do that investment. So we then try to have those that have those kind of equipment support all other countries, and then like we do best what you can do. So we allow collaborations, especially for Africa, because we cannot test enough because of capacity, and that is very key. Yes, when we have the capacity, which is not easy to come by, which is not easy to develop because of the constraints that are on our way. If we were manufacturing the same equipment here in Africa, and trainings would be easy, availability of equipment would be easy, yes, countries are going to develop more capacity easier and quicker. But this takes time. So take advantage of what we have and develop a team that work. So yes, we are not testing enough, but we can do much better than what we are doing. Increase the capacity within countries and also within regions and also within the African continent as a whole, where we can support each other in that context.
Now, my question is, would countries actually accept because there's this issue of sovereignty where countries want to be able to handle all of those aspects by themselves and not have to rely on others. So would the Gambia accept having to send their products to Ghana FDA labs, for example, to get them tested so that they are able to fill that gap? Do you think countries will accept this?
Okay, thank you. This is very easy. Here we are not talking about sovereignty without ability. We can't be so, but without ability to protect our own citizens. Does it work? Okay. Already in the current systems, we have got development partners that support these countries. And these countries, they receive results from other countries who test on their behalf through development partners. Say, for example, one of them is the UNDP Global Fund, which has been supporting a number of African countries and some Asian countries on quality control aspect of medicine, quality assurance. And they've been sending samples to WHO pre-qualified laboratories or ISO 17025 accredited labs to do the quality control testing. And then they use those results in their own countries. So yes, remember I said, WHO is encouraging for reliance networks. And the WHO has already developed a framework, a guideline on reliance, on how to rely on another labs, on how to rely on other national authorities. So it's not something that you will lose your sovereignty, because it's you who still decide how you accept the results. It's you in the country that still decide the framework on how you take the results and use them. So we are not saying that if one country tests medicine and then other one just accept. No, the countries analyze the results. They have got contracts. They have those countries. And then they act as, because at the end of the day, the contract giver will be responsible for the results. So they put issues they want that can be used to actually take responsibility of the results as their own. They put in the systems, they put procedures, they put guidelines and standards for that purposes. So they won't be losing anything. It's only that they don't have the capacity. You create systems, you make agreements, you provide ways of interpreting the results and how you accept them to use in your own country. And that does not say you have lost. Yes, I would want each country to have capacity to do their own testing, but with where we are, we can't let people die because of sovereignty. These things are already happening in the world over, whether at manufacturing level, you can subcontract another company to test for you, and then use the results according to the contract, and you don't lose because you return the results. And you also assess the labs that are testing. If they are doing very well, you test them, you check them, you assess them, and you see if they are competent enough. And by the way, we in this national medicine regulatory authorities, we have got a system from WHO for quality control labs, which is called WHO pre-qualification exercise. Yes. We also have got a system for ISO accreditation process that is standardized actual testing world over, using the same standard in Europe, in America, also in Africa. So if a lab is WHO pre-qualified or ISO 27025 accredited, it means the minimum required standard for quality control testing of medicines or medical products, which means their results are accepted anyway. Hence, you can take advantage of such systems and processes. That's the balance we can put. The sovereignty remains how you use the results, the responsibility. What strategy have you put to accept and use the results? That's your sovereignty. And we then be able to develop together.
Yeah, so the bottom line is to really make sure people are protected. Now, you were leading one of Africa's premier quality control laboratories at the Medicines Control Authority of Zimbabwe. What would you say was your greatest achievement leading those labs, and what level is that lab at compared to others in the region? You mentioned different capacities. Where does MCAZ sit on the continent?
What I would say is one of the achievements we made at MCAZ was to get all these international recognitions in terms of competence testing of medicines, particularly, and medical devices. So MCAZ was able to attain the WHO pre-qualification. And it was one of the very few labs in Africa. In fact, for pre-qualification, it was the fourth pre-qualified lab in Africa by then. That was in 2011. In 2013, when we got the pre-qualification. And in 2011, we also got 17025 ISO accreditation for the same competence of medicine testing. And that opened doors in terms of international scene. The MCZ then became a contractor to provide quality control services to the major international funding partners like the Global Fund, like even WHO itself. So the key message here is we managed to achieve to be a testing center, a regulatory center of excellence for quality control activities, where we would provide quality control testing training activities for other regulators, number one. We would also do quality control testing of medicines by these international donors like the UNDP Global Fund, WHO itself. So at one point, WHO, the MCAZ, was the quality control testing lab for 28 countries in Africa and in Asia. So that was a very big responsibility on part of MCAZ to be able to be the trusted partner by the Global Fund system. I think if you understand how it was international, partners do their work. It's very competitive. They don't need, they want things that are very organized, highly competent people, staff, and also high, properly governed systems and also institutions. So that was one of the key achievements for the laboratory. Number one, to be accredited. In a very short space of time, within 2 years, get WHO pre-qualification, and then to get contracts to do testing for Global Fund programs, WHO programs, UNICEF programs. And then the fourth one, to be the regional regulatory center of excellence for quality control activities, which means other countries will bring in their own quality control personnel to get some form of training, exchange programs, to learn on the ground, to do hands-on, to understand how to develop a lab, to understand how to develop a lab that is competent enough to provide quality control services that are internationally acceptable. So to me, I would say those were the great key achievements. Remember, this was being done where there are a lot of constraints in terms of resources. So there was a lot of resolute actions. There was a lot of, intentional ability and also excellent leadership from the DG who was there, who made sure that these things be met using the minimum resources that were available, so that MCZ will be able to protect its own citizens in Zimbabwe and also citizens of other countries that were seeking its services. So I can say those were the great achievements. And we have developed high-level competent experts where MCZ, Quality Control Lab, would then be able to allow its employees to be used for other capacity development activities across Africa. Especially for myself, I can speak for myself. I've been to a number of countries, assisting, strengthening them, developing them, capacitating them to be able to do quality control testing activities properly. So those are the key issues. So for me, it was personal level and also at institutional level.
Yes, many achievements. So a lot of development partners right now have been of course, working to support these labs across the continent to get to where they need to be. But there's also the problem of fragmentation. Too many supporting initiatives that do not talk to each other, which ends up burdening countries quite significantly. Can we get to where we need to be in terms of improvement with that fragmented approach? Do you see that at some point getting solved? For instance, could AMA be the answer? Could AMA be the agency that is able to get those different initiatives of different development partners to come and work together to actually start to have the kind of impact that is possible with that level of investment that is being made?
Well, looking at the level of support that Africa is receiving in terms of capacity building to the laboratories, what I like from what's happening within the African continent is these efforts of late have started to be consolidated into a standardized way, where the international partners coming in, we're no longer just coming at random, but there have been some frameworks that have been put in place. Let me start to refresh the memory. We had the first program that was offered by the USP through USAID in the past, where through a USP program that was in Ghana, where there was a development of national official quality control laboratories, a program that was called NOMCO Africa, in which USP was capacitating specifically those labs to be able to provide testing. And that has grown into a regional, into a continental body, with the Alga NEPAT, African Medicine Quality Forum, then took over and then continued to work with USP, USAID, and other partners to continuously support. So what I can say is the fragmentation was there initially, but in these times now, WHO is also pulling people together to work through its CIP network, Coalition of Interested Parties, where all partners come together, and then you understand your role, you define where you want to support, how you want to support, and then all the partners are aware that I am supporting to this level, and other partners supporting to this level. So there's a lot of concentrated effort that is now being done collaboratively outside the fragmented effort that was done before. Those were initial, and they worked very well to push for this coordination approach. So I can say where we are going now, yes, will be able to reach where we want, because now there's a lot of activities that are being done as a coordinated effort, number one. And also, remember, we have got these regional economies, SADC, the EAC, ECOWAS. These also have developed their own systems on how they can be capacitated. And also now coming in of African Medicine Agency, who also then reinforce all those activities that are being done throughout the continent, such that this fragmentation will be, to me, a thing of the past. And there will be more coordination, there will be more cooperation, and there will be more working together, where donors, partners come together in a single place, in a single pool of activities, and then you pick activities that you are able to do and support, and then you are then monitored how to do it, and then you work together with the host country or the host region. So I believe, yes, there's a lot of activities that are being done to pull together systems and to work together as a team, not in fragments. So I believe, yes, we can go and reach where we want to be, as long as we have developed systems, procedures, and the guidelines that control all these activities. Who is doing what, to what extent, and who can support the other, not to compete, so that we do the same thing at the same time. So that's what I believe is happening in terms of the quality control labs. A lot of push is coming through African Medicine Quality Forum, and that, as it is pushing more to the establishment of African Medicine Agency. I hope we see more and better things to come when the African Medicine Agency is finally operational.
Yes, that's very interesting, Colin. So now they are creating these forums that brings the efforts of donors so that they can work together, talk to each other in terms of how they are supporting and harmonizing those efforts for meaningful impact. But now, can it work? These efforts, can they work if they are working in a way that excludes local organization? The CIP network, for instance, I counted 2, I think, organizations that come from the African continent out of more than 20. And clearly, this is a system that is not very open to local organization. And watching these, what many people would be wondering is whether this approach can work. Again, we see this happening in many other areas where donors are involved. The approach is to really exclude, crowd out local companies so that donors, they know best, they do their thing. But do you see that approach working in the way it is right now?
So maybe let me start by addressing the issue where we are talking about international partners, where they're coming in. So basically, the reason why maybe most of our local partners or international local partners who could not possibly support was the issue of mismatch. Remember, these international partners were coming in with accepted and defined standards for the same area. And some local were not yet there in terms of level of expertise, number one, and also standard in recognition in the same part. And also, number 3, the actual capacity to provide both technical assistance and finance for particular activities to be accomplished. So it's not only about go local, but we have to have the locals that have enough capacity, number 1. They have to have enough competencies to create value and impact for what we want. So it's not excluding anybody per se, but the challenge is in terms of technical requirements that most of those locals that want to come in do not have or do not meet. I believe our local partners, they should first collaborate with those competent, those recognized, or they should get this kind of international recognition, standardization, so that they can come together and work together on others, not just come in as locals.
With the CIP network, though, it's very much that, isn't it? A platform for collaboration. And if you say that we are here to, as donors, if you say that we're here to improve capacity, but we don't want local organizations that are not at the right level. You have to be at the right level in order to collaborate with us, to be a part of the CIP network. Doesn't that defeat the purpose? I mean, can the efforts of donors, can they work on their own without incorporating or without working alongside other local agencies that are or organizations that are involved in the medicine supply chain? Can we say that, okay, we raise the standard of national medicines regulatory agencies and that solves the problem? Surely that cannot be it.
Okay, thank you for raising that kind of critical aspect. First of all, I would say, as we have already established, that in any system, for it to be sustainable, it has to involve the owners. There need to be some local ownership of any activity that's been done. So I would say, in whatever system that are being developed, there should be a critical component of local ownership of the activity. I don't mind having the local players develop capacity in one area, 2 areas, not necessarily everything, and then contribute that specific aspect and develop from there, besides collaborating with the international ones. But remember, there are those global ones like the WHO, UN, the Global Fund. They don't belong to any single country. So we have to meet their requirements for us to do them. But however, if we need other international organizations that can come into Africa to work specifically for the capacity building, from my experience, from what I've seen, all the African leaders, the political leadership is now talking about Africa focus within Africa, in Africa, for Africa. So what therefore we need is to tap into the expertise of those international ones, so that we can localize them to our Africa, to our continent. We then localize them, we adopt, and then we localize. What's the idea which I think was that gave to this issue was, in the past, we just received assistance, technical assistance, capacity building, but we did not localize anything. We continue to receive. But now, in this era now, the issue is localize, sustainability, put systems, structures, procedures, guidelines to enhance and ensure whatever is being done is able to be sustained locally after the partner leave or after the partners decide to support someone else. So yes, I believe it's important at this stage to have African programs, number one, and also African partners who are able to develop their capacity, train, look at opportunities. If it means working with those international ones, work with them so that you develop the required expertise, because the challenge mostly is only technical competencies, to provide a lasting or impactful solutions to some of these problems, some of these issues.
We'll leave it there. Thank you so much for coming on Utano Podcast.
Thank you, Lenias. Thank you for having me, and I enjoy listening to your programs, and I wish to contribute more whenever time allows. Thank you.